Welcome to The Explainer. Today, we're diving into a super practical guide for pharmacists on managing obsessive-compulsive disorder. We're going to focus on the clinical pearls you can actually use every single day in your practice. So, here's our roadmap. We'll kick things off with a quick look at what OCD really is, clinically speaking. Then we'll get into the two main ways to treat it. After that, it's a deep dive into the first-line meds, the SSRIs, and what to do when they don't work. We'll wrap it all up with some crucial counseling points for your patients. All right, first up, let's make sure we're all on the same page about what's going on inside your patient's head. OCD really boils down to two core symptoms: obsessions and compulsions. Okay, so obsessions. This is the internal storm. When a patient tells you they have these scary, sticky thoughts that just won't leave them alone, this is what they're talking about. And look, these aren't just your everyday worries. They are intrusive, they are deeply distressing, and they feel totally out of the person's control. And compulsions, well, that's the reaction. They're the things a person feels driven to do to try and get some relief from that crushing anxiety. It might be an external behavior you can see, like checking a lock over and over, or it could be a totally internal mental act, like counting in a specific pattern. It's their brain's attempt to neutralize the threat. Now, this number, 20 years, is so important to understand. That's the average age of onset. What that means is, for most adults you see at your counter, this is not a new problem. They might have been battling these symptoms, often in silence, for a decade or even longer. It's a chronic condition. So, how do we help them? Well, there are two main evidence-based pillars of treatment, and understanding the difference between them is absolutely key to understanding your role in all of this. So here we have this central challenge in OCD treatment. On one hand, you've got specialized cognitive behavioral therapy, or CBT. It's incredibly effective, and here's the kicker. The relapse risk is low after you stop. But finding a trained therapist can be tough, and it can be expensive. On the other hand, you have medication, which is way more accessible. And that's why, in the real world, meds are so often the first thing that gets tried. It puts you, the pharmacist, right at the center of that patient's journey from day one. And that brings us right to the heart of it, your core involvement, managing those first-line medications, the SSRIs. So let's get into the practical, day-to-day stuff you need to know. Okay, this slide is your script for setting patient expectations. And it's so important. You have to tell them two things. First, hey, you might feel a bit off at first, maybe some stomach upset, headache, even a little more anxiety. That's normal, and for most people, it gets better within a couple of weeks. Second, and this is crucial, this medication is not a quick fix. You need to be patient. They might start feeling better around 6 weeks, but it can take up to 3 months to get the full effect. That 4-week mark, that's really just an early checkpoint for the doctor. All right, let's talk specifics. They're all SSRIs, but they're not all the same. When you see a script for citalopram, especially at higher doses, think QTC prolongation. For fluoxetine, remember it can be activating, so you'll want to warn patients that their anxiety might tick up a bit before it gets better. With paroxetine, the keywords are anticholinergic effects, dry mouth, constipation, that kind of thing. And sertraline, don't be surprised if you see a dose like 400 milligrams. For OCD, specialists push the dose way higher than you'd ever see for depression. So, this is the standard playbook. It's a pretty straightforward process. Titrate up, check in at 6 weeks, but look at step 4. If the patient isn't getting better, the very first move isn't to switch meds or up the dose. The first question is always, is the patient actually taking it correctly? That's where you come in. Your role in checking and encouraging adherence is absolutely critical. Okay, so what happens when you do everything right? The patient is adherent, the dose is optimized, and that first SSRI just doesn't cut it. Well, the guidelines give us a clear path forward. This is a really common clinical problem, and the answer is why you'll start to see some more complex medication profiles for these patients. So the next move isn't a random guess. The evidence points to two main strategies. You can either switch to a different SSRI and try again, or, and this is super common in practice, you augment. That means adding a second medication. And for treatment-resistant OCD, aripiprazole and risperidone are the first-line go-to choices for augmentation. Now, as soon as you see a prescription for aripiprazole or risperidone added to that SSRI, a little alarm bell should go off in your head for metabolic side effects. This is a huge opportunity for you to provide a critical safety check. You need to be counseling these patients on watching for weight gain and telling them how important it is to get their blood sugar and cholesterol monitored regularly. All right, let's wrap things up with a few high-yield counseling situations that you are, without a doubt, going to encounter in your practice. You are going to get this question. For your patients who are breastfeeding, this is a vital piece of information to have ready. If they need to be on a medication, sertraline and escitalopram are generally the preferred options. And the reason is simple. We have data showing that they passed into breast milk at really low, often undetectable levels. And finally, we have to talk about stopping treatment. This is a massive counseling point. You have to be straight with patients. Relapse rates after stopping medication are really high. A slow, gradual taper is non-negotiable. But maybe the most important thing you can tell them is this. Combining their medication with that specialized CBT we talked about, that is their absolute best defense against a relapse. And that really brings us to the big picture here. The medication is what gets patients stable enough to function again, but it's the specialized therapy, the CBT, that teaches them the skills to stay well in the long run and prevent relapse. As a pharmacist, you often see the patient more than anyone else on their healthcare team. You are perfectly positioned to be that bridge between these two pillars, constantly reinforcing why both are so important. You can help guide your patients from just responding to treatment to truly achieving a lasting recovery.